We just heard what I would say a bombastic talk on inherited bone marrow failure syndromes, where they identified a whole lot of new ones, and it's going to change the way we look at it and management. I'm going to talk to you what we do on a day-to-day basis in our clinic. So we need to be able to differentiate acquired bone marrow failure from inherited bone marrow failure, because it's going to be applicable to us in our, in our planning, our management. So in children usually present with features of anemia, thrombocytopenia, which presents with bleeding, or recurrent infections because of leukopenia. So the types of bone marrow failure is broadly classified to acquired bone marrow failure or inherited bone marrow failure. The extent of hematological manifestations depends on the extent of cytopenia, whether they have isolated cytopenia or pancytopenia. When we look at acquired bone marrow failure, it says that 70% of our bone marrow failure or aplastic anemia that we see in the clinic are acquired aplastic anemia. The peak incidence is in adolescents and young adults. It's mainly an immune-mediated disease. Occasionally, drugs, toxins, and infections may contribute to the pathogenesis. There is pancytopenia, hypocellular marrow, without dysplasia or fibrosis. It is very important that we differentiate hypoplastic MDS and PNH in a case of acquired bone marrow failure syndrome. It is actually a diagnosis of exclusion. When it comes to inherited bone marrow failure, the literature says up to 25% of cases are bone marrow failure, inherited bone marrow failure syndrome. But I'm beginning to think that as we recognize more and more different types of inherited bone marrow failure syndrome, the percentage is only going to increase. The most common types that we see are Fanconi anemia, dyskeratosis congenita, Shwachman-Diamond syndrome, Diamond-Blackfan anemia, congenital A-megakaryocytic thrombocytopenia, and a few other rare types. So these diseases classically present with congenital malformations or certain phenotypes, and these are extra hematological manifestations. And presence of these in the clinical setting should give us a clue to the diagnosis. However, it's important for us to know that absence of this does not rule out an inherited bone marrow failure. So what I have done is I have compiled common clinical features in the most common types of inherited bone marrow failure syndromes that we see in clinical practice and compared that with acquired bone marrow failure. If you look at hematological manifestations, it can vary from isolated cytopenia and clinical features secondary to that, like in a Diamond-Blackfan anemia, where it's a pure red cell aplasia, or in congenital A-megakaryocytic thrombocytopenia, where it's only thrombocytopenia and absent megakaryocytes. In children or infants rather with Shwachman-Diamond syndrome, they classically present with neutropenia, which will later on develop pancytopenia and move on to hypoplastic bone marrow. Many cases of Fanconi anemia and DKC to start with may present with only thrombocytopenia, later progress to full-blown pancytopenia and hypoplastic marrow. As opposed to an acquired bone marrow failure, what we see in our clinical practice, most of the severe types present with pancytopenia. Family history is very important when we are dealing with a bone marrow failure in our clinical setting. So in almost all cases of inherited bone marrow failure syndrome, you may get a history of some relative or close family relative with unexplained cytopenia, an MDS, or a myeloid neoplasm. In those with Fanconi anemia, you may get history of head and neck malignancy. Triad of pulmonary fibrosis, liver fibrosis, and early graying, less than 25 years, may give us a clue that we may be dealing with a child with dyskeratosis congenita. Neonatal deaths due to malabsorption, infection, or severe failure to thrive may indicate that we are dealing with a Shwachman-Diamond syndrome. Age of onset is important. There are 3 of the 5 inherited bone marrow failure syndromes I've listed here, classically present in the infancy. These are Shwachman-Diamond syndrome, Diamond-Blackfan, and CAMT. Children with Fanconi anemia, by the time they come to our clinic, they're between the ages of 5 and 10, most of them. Some may come much later in life. And dyskeratosis congenita and acquired bone marrow failure, what we see in our pediatric clinic, usually children are at least 10 years or older. Skin manifestations are classically seen in Fanconi anemia. These are cafeolar spots, hypo or hyperpigmented skin lesions. And what is unique about dyskeratosis congenita is a triad of reticular skin lesions, nail dystrophy, and mucosal leukoplakia. Children with inherited bone marrow failure syndrome have skeletal and limb anomalies, which will give us a clue as we are seeing them in the clinic. These are hypoplastic thumb anomalies, flat thenar eminences. Triphalangeal thumb is classical of Diamond-Blackfan anemia, and there'll be metaphyseal dysostosis, syndactyly, and various other anomalies seen in these syndromes. Craniofacial appearance gives us a clue to the diagnosis. Fanconi anemia, classically present with microcephaly, triangular faces, mid-facial hypoplasia, and small eyes. Microcephaly is also seen in DKC and in Diamond-Blackfan anemia. So when we look at the general stature of the child, the Fanconi anemia classically have short stature. And if you look at the birth history of these children, many of them may have had low birth weight. Those with Shwachman-Diamond syndrome had severe failure to thrive. Because bone marrow failure, inherited bone marrow failure syndromes are multi-system disease, we will see multi-system involvement. And in fact, all of them are likely to have some cardiac malformations and genitourinary malformations. Those with Fanconi anemia, we may see a VACTERL spectrum of VACTERL complex. Exocrine pancreatic insufficiency will give us a clue about Shwachman-Diamond syndrome. So when we are sitting in the clinic and trying to establish a diagnosis, I think we should become a general pediatrician to take a detailed history, including a family history, and examine the patient head to toe, and then start investigating the patient. So in the clinical history, it is important to ask the duration of symptoms, whether it's a long-standing or chronic anemia, as opposed to an acute onset severe anemia, which may give us a clue whether we're dealing with an acquired or an inherited problem. Severity of symptoms or a predominant symptom will let us know that which cytopenia that we are dealing with. It may be anemia, in red cell aplasia, bleeding manifestations when the platelets are involved, infections, recurrent infections in leukopenia, or a combination of all this. Neonatal history is important. Growth and development, developmental delay, and failure to thrive will give us a clue to our diagnosis. Since most of these diseases are multi-system, we must look at other systemic manifestations such as diarrhea and malabsorption, cardiac anomalies, and symptoms or complications due to genitourinary abnormalities. History of exposure to drugs and toxins and recent infections may give us a clue about towards acquired bone marrow failure. Family history, children with early childhood deaths due to infection, bleeding, failure to thrive may tell us that we are dealing with a family who's had a child with Shwachman-Diamond syndrome. Many of these patients with inherited bone marrow failure syndrome, we may get a family history of MDS or acute myeloid leukemia. In those with Fanconi anemia, most common solid malignancies that we see are squamous cell malignancies in the head and neck region. Liver and lung fibrosis and early graying, less than 25 years old, will give us a clue that we may be dealing with DKC. A detailed head-to-toe examination, as a pediatrician says, is important, and anthropometry will definitely give us a lot of information, as most of these children have severe failure to thrive and they are stunted. Head circumference will give us, help us make a diagnosis of microcephaly. Look carefully at the myriads of facial features that we can pick up and which may help us in our diagnosis. Do not forget to examine skin, nail, and hair. Look at oral mucosa for leukoplakia, skeletal and limb anomalies, cardiac and pulmonary and genitourinary abnormalities. So once we have examined the patient, taken a good history, you can start investigating, because we may have had some clue I have actually divided them into primary investigations, which we do, and probably more sophisticated specific investigations, which we may have to refer to a specialized lab. And these tests include usual CBC retics, liver and renal function test, B12 folate. We look for hepatitis screen, HIV and parvovirus, looking for viral infections. All children will need a bone marrow aspiration and biopsy and conventional karyotype, stress cytogenetics, a flow cytometry for PNH, and in certain situations, HbF estimation will give us some clue as some of these inherited bone marrow failure syndromes may have elevated HbF. Specific investigations in cultured skin fibroblast tests for Fanconi anemia, as the regular stress cytogenetics may miss some of the cases, flow fish from peripheral blood for telomere length, and NGS targeted panels for genes. So these are the investigations that we need to do, and some we may have to refer to higher centers for specialized investigations. So to summarize what I have said so far, in the clinical setting, acquired bone marrow failure is seen in older children. Many of them have an acute onset. They have normal growth and development. They may not have any dysmorphic features. It is usually a single system disease and not a multi-system disease as in inherited bone marrow failure syndrome. They have trilineage hypoplasia, and the pathogenesis is in most cases immune mediated, maybe drugs or infections in smaller proportion of cases. It is important to have, it's a diagnosis of exclusion, so we must rule out hypoplastic MDS and PNH. When it comes to inherited bone marrow failure syndrome, it can start from neonatal period to late into adulthood. So it often has an insidious onset. Many children can have failure to thrive, and they have characteristic external features. It's a multi-system disease. May start with one or two lineages involved and eventually leading to trilineage hypoplasia. The pathogenesis broadly, and there are many more mechanisms, but broadly three: DNA defects in DNA repair, telomere biology, and ribosomal biogenesis. And almost all cases have cancer predisposition. So if it is not, if it's so clear, why is it difficult? It's often very difficult and challenging to make a diagnosis because the usual signs and symptoms and family history may be absent in a case, or maybe findings are very subtle in up to about 40% of cases. We also know that all this is overlapping spectrum of syndromes extending from inherited to acquired and PNH, AML, and MDS. So it is sometimes very challenging to differentiate one from the other. We saw the slide this morning at Dr. Young's speech, at his talk. So, so the treatment also, it's different based on the pathophysiology. It's an immune-mediated destruction will respond to immunosuppressive therapy and bone marrow transplant. Those with inherited bone marrow failure syndrome, when we are planning transplant, it will have to be different from somebody who doesn't have a constitutional problem. And not those ones not for transplant may respond to androgenic steroids. I think the previous speaker has already shown us this. So how do there's a workflow for evaluation and treatment in the clinical setting. Once we have taken a clinical history examination and done the standard basic blood test, we look for features of any inherited bone marrow failure syndrome. If they have any features or we have a doubt, we must investigate them for specific tests to exclude or diagnose an inherited bone marrow failure syndrome, because it's going to affect our management. Those with inherited bone marrow failure syndrome need transplant. They will need special conditioning and special donor selection. Those who do not have any clinical features and less than 40 years, if they are planning to go for a transplant, my understanding is that anyone who's going for a transplant will need certain amount of screening to rule out at least Fanconi anemia and dyskeratosis congenita. So the rationale to distinguish acquired bone marrow failure from inherited bone marrow failure, as I said, it's an overlapping syndrome. About 1/3 of the cases may not have pathognomonic physical features and may present later on in life with just bone marrow failure or a malignancy. It is important for us to know the natural history of these diseases for better understanding, for counseling, and for planning management. It is also important for us to differentiate between the two conditions, two spectrum of diseases to institute appropriate therapy, as we know that immunosuppressive treatment do not work in those with inherited bone marrow failure syndrome. And if we making a diagnosis, we may lose the patient because of treatment-related mortality. While we are planning bone marrow transplant for these patients, those with inherited bone marrow failure syndrome, especially Fanconi anemia and DKC, will need very less intensive conditioning for bone marrow transplant because of the potential toxicity from standard conditioning regimens. And while choosing a donor, it is very important that we need to screen the family members for potential diseases, which are subclinical diseases. Last but definitely not the least, we need to prognosticate and also for ongoing surveillance. So this is the end of my talk, and these are my references. Thank you very much.